Hello, Dr. Raymer here. Today we're going to talk about internal structure of the brainstem with the specific objective of linking damage in different portions of the brainstem to neurological symptoms and signs. Now, when we want to talk about linking brainstem anatomy to clinical presentation and the result of lesions, we have to think about a few things. First, we know that deficits are produced by both white matter damage, i.e. damage to tracts passing through the brainstem, and gray matter damage to nuclei that reside within the brainstem. And that would be cranial nerve nuclei and other nuclei. You could also have damage to cranial nerves attached to the brainstem. So that's also possible. When we talk about deficits or constellations of deficits, which are often described as brainstem syndromes, we talk about them in multiple ways. We talk about the structure damaged to produce the deficit, the symptom or sign that results, the part of the body that's affected. We'll talk about sort of head and neck together, and body. We will not talk about organs, but of course there are visceral effects of damage to cranial nerve nuclei. And finally, laterality, left or right side of the head or body. Now, as a general rule, there's a rule about laterality in the brainstem. It's that brainstem lesions typically produce symptoms that are alternating. In other words, one side body, opposite side head and neck. It's not a perfect rule, but it's a common starting point. In addition, because we're in a tiny, tiny structure here, it's easy to forget when we look at these big pictures like this, right? But the brainstem is sort of the diameter of your thumb or less along most of its length. And so damage in this compressed region of nuclei and tracts nearly always affects more than one structure and therefore produces multiple deficits. And finally, a common mechanism of brainstem damage is stroke. Now, I use the word common here. I just want to clarify. Brainstem strokes are relatively rare. When they occur, because of the complex anatomy of the brainstem, they can be catastrophic. So I'm using the word common here to refer to a common variety of brainstem damage, not a common clinical situation in general. Now, the brainstem is supplied by the posterior circulation, or the vertebro-basilar circulation, and that circulation consists of these three major arteries, plus I'll call them the three cerebellar arteries. So let's take a look at that. We know that in most people, the vertebral arteries arise from the subclavian arteries, which aren't shown here bilaterally. They ascend over the medulla and fuse at the bottom of the pons to give rise to the large central basilar artery. And it in turn splits again at the level of the midbrain to give rise to the posterior cerebral arteries, which travel posteriorly over the cerebral peduncles. And so those are the three major arteries. Along the way, we see a few branch points, and those are the cerebellar arteries. So the posterior inferior cerebellar artery is here, shown in yellow, typically arising in most people from the vertebral arteries. The anterior inferior cerebellar artery is here, shown in purple, typically arising from the caudal portion of the basilar artery. And the superior cerebellar arteries arise here, typically from the top of the basilar artery to spread posteriorly. So, posterior inferior cerebellar artery, anterior inferior cerebellar artery, superior cerebellar artery. If we look at that again in lateral view, this is a similar view to what we saw in the previous slide. I will say this is a bit more correct, and that's because it features these short paramedian branches of the basilar artery that spread over the pons laterally. So if you go back to this nice color-coded figure, you might want to add a few of those in for yourself, just as a reminder that those branches are there. And if we look at the lateral view again, we can see the posterior inferior cerebellar arteries. Here they are. The anterior inferior cerebellar arteries arising here. There they are. And the superior cerebellar artery, I have to squint there. It's the branch point spreading posteriorly. So it's these 6 arteries that supply nearly all of the brainstem territory. But what's confusing when you look at a vascular map, a vascular supply map of the brainstem, as we will in a second, you often see that different portions of the brainstem in transverse section are supplied by the same artery. And that's because all of these arteries give off penetrating branches as they travel around the brainstem. And so this diagram illustrates that quite nicely. So you might picture this circumferential artery spreading around as being the posterior cerebral artery, for example. And on its journey around the brainstem, it gives off branches. And so these are described in different ways. They might be described as paramedian penetrating arteries, just near the midline, or penetrating arteries of short circumferential branches, or penetrators from long circumferential arteries. And they supply more lateral portions. And so that's what we mean when we say the branches supply different bits. Now, if we return to the slide for a second, I've cleared off my drawing so you can see the nice color coding. You can start to see what is supplied by what. So if we start at B4, in the level of the caudal medulla, remember that the caudal medulla is almost a continuation of the spinal cord. And so the anterior spinal artery and the posterior spinal artery supply portions of the caudal medulla. The vertebral artery at this level fills in the gap. So the vertebral artery fills in the lateral portion, and the spinal arteries fill in predictable bits of territory. If we move up to B3, now we're more rostral in the medulla. We know that because we see the wiggly, squiggly olivary nucleus. At this level, the vertebral arteries supply almost all of the medial portion, while the pica, the posterior inferior cerebellar artery, supplies the most lateral portion. And again, it's the long circumferential branches of the posterior inferior cerebellar artery that do that. So this, you could picture that artery traveling all the way around and then giving branches to supply the lateral portion. If we move into the pons, more rostrally, so this is B2, that's the level of B2 there, we can see that the ICA is important laterally in the pons. Well, that's the branches of the basilar artery that supply most of the middle of the pons. And I'll just draw those branches in for you as a reminder that they're there as part of that deep purple territory. And finally, in the midbrain, if we look at B1 here, this is a transverse section from the level of B1, and the cerebral peduncles, those are visible anteriorly or ventrally here. We can see that almost all of this level of the midbrain is supplied by branches of the PCA, the posterior cerebral artery. And so the superior cerebellar artery makes a small contribution, I think. I think that's what they're trying to show with this blue and red. But a large portion of the midbrain is supplied by the PCA. And once again, it's those deep penetrating branches of the PCA that it gives off as it travels around the brainstem. So armed with all of this information, we will take 6 scenarios to examine the effects of brainstem stroke, linking anatomical damage to clinical outcome. So we'll start with our first scenario, which is lateral medullary syndrome. The eponym is Wallenberg syndrome. And the cause of this is often a vertebral artery stroke or a posterior inferior cerebellar artery stroke. And this is just an alternate map of blood supply to the medulla. And just to orient you, here we're caudal. In fact, we're in the cervical spinal cord, moving more rostrally, and then coming over here, a little bit more rostral, and so on. Here we're in the rostral medulla, the most rostral portion of the medulla. And you can see the variation. And so here, of course, the whole cervical cord, almost, is supplied by the posterior and anterior spinal arteries. The vertebral artery begins to make a contribution right at the cervical medullary junction. And then if we move all the way up, we can see a couple of trends. The pica, which is orange in this schematic, supplies quite a bit of the lateral medulla, while the anterior spinal artery and the vertebral artery supply the medial medulla. So in this case of lateral medullary syndrome, here is an example of a section where the zone of damage produced by a pica occlusion is shaded. And these schematics are nice because you can see the relevant structures that are affected. So what are the motor signs for the body in this type of lesion produced, in this case, by a left pica arterial occlusion? Well, there's no paralysis because the corticospinal tracts and the pyramids are spared. However, there's ipsilateral ataxia because of damage to the inferior cerebellar peduncle. So because that communication between the brainstem and the cerebellum is disrupted, typically there's ipsilateral ataxia. And the clinical sign of this is patients fall toward the ipsilateral side. Now, in addition to this ipsilateral ataxia, another characteristic sign of Wallenberg syndrome is dysphagia and dysphonia. And that's due to damage of the nucleus ambiguus, which is right here, which receives input from cranial nerves 9 and 10 and innervates muscles of the pharynx. Now, in terms of sensory signs for the body, fine touch and proprioception are intact because the medial lemniscus is spared adjacent to the midline, but the spinal thalamic tract is typically disrupted by this lesion, and that results in contralateral loss of pain and temperature in the body. In terms of the head and neck, we have ipsilateral loss of pain and temperature, not due to a tract this time, but due to nuclear damage. So we have damage to the spinal trigeminal nucleus, which is here and here. And this is illustrative of that phenomenon, but the brainstem, right? So contralateral loss of pain and temperature in the body, ipsilateral loss of pain and temperature in the head and neck. So this is a nice clinical summary of Wallenberg syndrome, illustrating the arteries typically involved, the structures that become ischemic, and the clinical signs and symptoms that result. Here they're showing the posterior inferior cerebellar artery infarct, and that's what we showed on the previous slide. An alternative, similar but not identical situation could be produced by a vertebral artery occlusion. And I'd invite you to think about the differences clinically between these two scenarios. How would they present differently? The second scenario we'll look at is medial medullary syndrome, and this is should be an accent aigu, I believe. Dejerine syndrome is the eponym for this. And a common cause of Dejerine syndrome is anterior spinal artery occlusion, and that's what's shown shaded in this diagram here. So this time, the most obvious motor sign for the body is contralateral weakness or paralysis due to damage of the medullary pyramid, ventrally and medially. There's no ataxia because the cerebellar peduncle is spared. So the cerebellar peduncle is intact, but we now have paralysis. The most obvious motor sign of the head and neck is deviation of the tongue, and that's due to damage of the hypoglossal nucleus. That is right here, EC, since we're in French. And this damage to the hypoglossal nucleus causes paralysis of ipsilateral body of genioglossus, which results in deviation of the tongue to the ipsilateral side. Now, in terms of sensory signs for the body, we have the contralateral loss of fine touch and proprioception due to damage of the medial lemniscus. And as a caution, the laterality of this deficit depends on the level of injury in the medulla. So I'd like you to think about that. At what level in the medulla has this information crossed the midline? That will dictate what the outcome of medial medullary syndrome is. Where this syndrome occurs, rostral or caudal in the medulla. So our next example is lateral pontine syndrome. And this typically results from an anterior inferior cerebellar artery occlusion. Now, lateral pontine syndrome has similar consequences for body as lateral medullary syndrome, so the tract-mediated consequences are similar, but because we're at a different rostral caudal level of the brainstem, the deficits, I couldn't even say deficits, I'm experiencing a deficit right now. The deficits related to cranial nerve nuclei are different. So, similar body, different head and neck and face deficits. Here we're in the caudal pons, and I'll show you how I know, because I can see cranial nerve 7, the facial nerve, swooping in little U's here. and that's a landmark for the caudal pons. And recall that it swoops right over the abducent nucleus. So if you see cranial nerve 7 like that, you know you're in the caudal pons. So here's another vascular schematic. This is the caudal pons right here. This is the most caudal. It's a P, PP. Section of the pons shown. And then next most caudals here, and then most rostral in the pons is here. And you can see how the supply changes a little bit. The whole medial pons is supplied, coated in purple, supplied by paramedian branches of the basilar artery. So those critically supply the medial pons, while branches of other arteries, notably the anterior inferior cerebellar artery and the superior cerebellar artery, supply the lateral portions of the pons. So here we're looking at a scenario where the left anterior inferior cerebellar artery has been occluded, and the zone of damage again is shown in gray in the schematic. So in terms of motor signs for the body, similar to lateral medullary syndrome, there's no paralysis. There is ipsilateral ataxia, this time due to damage of the middle cerebellar peduncle. And the middle cerebellar peduncle is huge, so is likely to be pronounced ataxia. In terms of the head and neck, the most prominent motor sign is paralysis of the ipsilateral half of the face. And that is, of course, we just spoke about, due to damage of the facial nucleus. Now, in terms of sensory function, again, there's no loss of fine touch and proprioception. There's contralateral loss of pain and temperature in the body, and that's because the medial lemniscus is spared and the spinal thalamic tract is damaged. Here's the tract damage. In terms of the head, face, and neck, there's damage to the spinal trigeminal nucleus, and that causes ipsilateral loss of pain and temperature in the face. It can also involve ipsilateral loss of fine touch, proprioception, etc., due to damage of the chief sensory nucleus in the pons. So remember, we have these two sensory nuclei. The spinal trigeminal nucleus is present almost throughout the brainstem. The chief sensory nucleus only in the pons. Now, medial pontine syndrome most commonly results from occlusion of one of those little paramedian branches of the basilar artery. So again, we go back here for a second. Here are the little branches of which we speak. Now, this has similar consequences for medial medullary syndrome, but for two exceptions. First, different nuclei are affected, obviously. And second, the deficits are likely to be selective. If you have one little occlusion, it's likely it's going to affect one of these paramedian branches. And because there are multiple branches, a single infarct is likely to produce a subset of all of the clinical signs in medial pontine syndrome. So here we can see the type of infarct that might result from occlusion of one of those paramedian branches of the basilar artery. And predictably, we have paralysis contralaterally in the body due to CST damage. That's easy. In the head, face, and neck, the most prominent motor sign here is likely to be ipsilateral lateral rectus muscle paralysis. So lateral rectus palsy affecting the ipsilateral eye. And that's due to damage of the abducent nucleus right here. There may also be facial weakness here. And that's due to damage to the facial nerve as it passes over that abducent nucleus. So while the facial nucleus itself isn't included in this infarct, damage to the fibers exiting it could produce ipsilateral facial weakness and paralysis. So this is what a patient with a left abducent nuclear or nerve injury might look like. So if you ask them to look straight ahead in primary gaze, you'll notice this is the affected eye. Their left eye is drifting medially. And that's due to the unopposed action of medial rectus. It's functioning normally. Lateral rectus is paralyzed. If you ask that same patient to look to their right, there's no problem. The left eye behaves normally because it can still adduct just fine. If you ask the patient to look to their left, the left eye cannot. And the left eye, the lesion's obvious immediately because the patient cannot abduct that eye. Now, in terms of sensory signs for the body, there's medial pontine syndrome often presents with contralateral loss of fine touch and proprioception, and in this case, the medial lemniscus is undoubtedly crossed, so that loss will be contralateral. Now, moving rostrally, we'll look at lateral midbrain syndromes. And most midbrain syndromes result from occlusion of a penetrating branch of the posterior cerebral artery. So most of the midbrain is supplied by some branch of the PCA. Now we can see that here. Let's just take a little look at this diagram again. So here is our posterior cerebral artery. We'll look at the left one. And then let's look at B1. And you can picture the posterior cerebral artery traveling around the outside of the brainstem and giving rise to branches all along its length. So we have paramedian branches, which supply the most medial portion of the brainstem, short circumferential branches, and long circumferential branches. And that's the progression, proximal to distal, of the branch pattern supplying the midbrain. So let's look at the lateral midbrain syndrome produced by a penetrating branch of the PCA. If we want to relate this schematic to this schematic, we could imagine it being a short circumferential branch, something sort of midway along its length, and that would take out a lateral wedge of the midbrain. So the motor signs here for the body are now due to damage of the cerebral peduncle. And so a swath of that cerebral peduncle will be ischemic, and it of course contains the CST and the CBT. And that has the potential to cause contralateral weakness or paralysis in the body and the head, face, and neck. Now, the contralateral cortical bulbar tract weakness is most apparent in relevant cranial nerve nuclei, i.e. those with strictly contralateral innervation. You'll also have, if it's at this level, contralateral ataxia and tremor, and that's due to another nucleus, the red nucleus. So this is not a cranial nerve nucleus, this is the red nucleus, and you'll recall that the red nucleus gives rise to the rubrospinal tract, rubrospinal, which innervates proximal musculature, crucial for posture and balance. And that's what's giving rise to the contralateral ataxia in this case. Now, if the syndrome here affects the ocular motor nucleus, and it's shown here in yellow, then we get an ipsilateral ocular motor nerve or ocular motor nuclear damage, ipsilateral ocular motor palsy. This is apparent right away. So this eye, the affected eye, this is again a left ocular motor paralysis, in primary gaze looks down and out. And that's due to the unopposed action of the two remaining extraocular eye muscles, the superior oblique and the lateral rectus. And finally, we come to medial midbrain syndrome, or Weber's syndrome. This also results from occlusion of a branch of the PCA, but it's a more proximal branch, or a paramedian branch, for example. And so this is the type of infarct that might result from that proximal or paramedian branch. And I'd just like you to put those terms in there so you can distinguish between proximal or paramedian, close to the midline, short and long as you move proximal to distal through each artery. So if we take this proximal and paramedian branch, we still have the potential for both corticobulbar tract and corticospinal tract damage, and there's typically no sensory signs. So both of the major sensory pathways are spared in this case. In the midbrain, you can still get ocular motor nerve palsy. This is a little bit more of a complete schematic description of that compared to the clinical picture we saw before. So again, this is in primary gaze. This is the affected eye. The eye at primary gaze, or look straight ahead, rests down and out. The pupil is often also dilated and unresponsive. And the eyelid droops. And all of these are a consequence of ocular motor nucleus damage.